Okay, everyone, thank you very much. We are going to start now with the pneumococcal session. This is the next session and the only session before our lunch break. So we're going to ask that Dr. Grace Lee start with her introduction to the work group.
I'm very pleased to be here on behalf of the pneumococcal work group, and some of the members are in this audience. We have an excellent group of experts who are willing to dedicate their time to some really difficult questions that we have on hand. Would like to thank my ACIP members, specifically Paul Hunter, who's currently on the work group, as well as some new liaison representatives and consultants that have joined our work group. And then especially a special thanks to Tamara Pilishvili and Almina Madanak, who are fearlessly leading this really complicated work group. Our terms of reference are to review the current data on efficacy, effectiveness, immunogenicity, and cost-effectiveness of pneumococcal vaccines, to review the current recommendations, considering up-to-date evidence, including epidemiologic studies, and to assess the strength of that evidence, and to revise or update recommendations for pneumococcal vaccine use as needed. As you recall, we ACIP recommended PCV7 vaccination for kids in 2000, followed by PCV13 implementation in 2010 when that became available. In 2012 to 13, there was a recommendation made by ACIP at the time to provide PCV13 for individuals with immunocompromising conditions. And then in 2014, ACIP recommended PCV13 in series with PPSV23 for the adult population, those 65 and older. And we are currently now reevaluating that recommendation from 2014. When that recommendation was made in 2014 to give PCV13 in series with PPSV23 for adults 65 and older, the thinking was that this was a short-term recommendation, but that it was warranted because while the indirect effects had decreased vaccine-type IPD from the infant population or the child population, there was still a significant burden of pneumonia, especially among older adults. And that the long-term public health benefits at that time were expected to be limited because of the anticipated continued indirect effects from the pediatric PCV13 program. Therefore, the recommendation was made with a commitment to reevaluate this policy 4 years later and revise as needed. So it is now 2018, and we are still in process of reevaluating this recommendation. We have been monitoring pneumococcal disease, including both invasive disease and non-invasive pneumonia among adults 65 and older. Evaluating the impact of direct and indirect effects of pneumococcal disease on, in adults 65 and older, and we continue to monitor vaccine safety. So as a reminder of how sometimes complex our recommendations are in terms of implementation, we are focused on that red box in the right upper half of the slide and looking at the PCV13 recommendation for those 65 and older in immunocompetent patients with and without chronic health conditions. We are not reconsidering the recommendation for immunocompromised persons, persons with functional or anatomic asplenia, or for those with cochlear implants or CSF leaks. That will remain in place. So today's session will include a presentation by Dr. Tamara Pilishvili on PCV13 impact on invasive pneumococcal disease and serotype distribution for the remaining disease burden, with a particular focus on adults 65 and older. Ryan Gierke will present on the incidence of non-invasive pneumococcal pneumonia among adults 65 and older. Dr. Fernanda Lessa will discuss the impact of the introduction of infant vaccination program with PCV13 on pneumonia and IPD in the U.S. from 2005 to 2014, so before the recommendation for those 65 and older. And then we will hear from Dr. Charles Stocker an economic analysis of continuing the recommendation to immunize with PCV13 for the older adult population in the context of continued herd immunity from the childhood immunization program. And then finally, we will wrap up with a presentation by Dr. Almina Madanak on some preliminary discussions on the EtR framework for the ongoing review of this recommendation. And so our discussion question for the group today in the session is to really help us think about the EtR framework going forward. So you will not hear all the components of the EtR framework today. We are presenting this at an earlier time point than usual, in part because this is a challenging decision ahead. You will start to hear, and we are nearly complete with all of the information on benefits and risks. and resource use. That is also underway and still ongoing discussion, but you'll start to hear the beginnings of that today. We also need to consider values, acceptability, and feasibility. So our question to our ACIP members are which domains warrant additional exploration and what questions do you have for the work group that you'd like to hear about? Thank you.
Great, thank you. And as Dr. Pilashevi is coming up, I just want to let the ACIP members know that we are printing the slides for the session right now, and they'll be distributed momentarily.
Good morning, and thank you, Dr. Lee. So the focus of my presentation is to update this committee on the impact of the PCV13 introduction for children and then for adults on invasive pneumococcal disease. This is an update that we have provided almost every year, and the current update includes surveillance data through 2017. But we also, what I also wanted to do is focus on the remaining disease burden and describe remaining serotype distribution for the remaining disease burden after 7 years of PCV13 use in the US. The data that I'm going to present comes from active bacterial core surveillance. It's active population and laboratory-based surveillance that is ongoing at 10 US sites. The definition of invasive pneumococcal disease cases, pneumococcus should be isolated from a normally sterile site. Isolates are serotyped by quelling or PCR at our reference laboratories, and for this analysis, I'll group them as PCV13 types. Those are the serotypes contained in a PCV13, but we're also including serotype 6C, which has shown cross-protection from the 6A antigen in a vaccine. And non-vaccine types includes all other serotypes that are not included in PCV13. We are using US Census Bureau Race-Bridge post-census population estimates as our denominators, and we'll be looking at overall and serotype-specific IPD incidence rates as cases per 100,000. So the data presented on this slide looks at trends from 2007, that is before PCV13 was introduced for children, through 2017. Blue line represents changes in all invasive pneumococcal disease, and orange line is the vaccine serotypes. As you can see, shortly after PCV13 was introduced, we saw reductions in overall disease driven by reductions in PCV13 types combined with the serotype, cross-protective serotype 6C. But since 2013 through 2017, these remaining vaccine serotypes the disease has leveled off, and we have not seen any additional reduction, although the burden of disease is very low. It's less than 2 cases per 100,000. In terms of non-vaccine serotypes, the gray line, we have not seen any changes or any evidence of disease replacement due to these serotypes. Now on to adults 65 and older. So the period of time from 2010 through 2014, before the vaccine was introduced for adults, these are indirect effects from the pediatric use of PCV13. As you can see, overall and vaccine type disease reduced in very similar picture to what we saw among kids, dramatic reductions in disease caused by these serotypes. But after 2014, the disease rates have leveled off. So since the vaccine was introduced for adults, we have not seen any population level impact of this vaccine. And for non-vaccine types, similar as for children, we don't see evidence of serotype replacement. Now, in terms of which vaccine serotypes contributed to these reductions, so among children, most of the reductions are due to serotype 19A and 7F. So this is like orangish red portion and a blue. And serotype 3, which is presented here in green, we saw some evidence where we thought that the reductions were occurring, but as you can see from 2012 through 2017, the rates remained the same and have not really changed. We see one of the PCV7 serotypes, 19F, that has persisted and even increased slightly, and that's presented with a yellow portion. For adults 65 and older, again, similar picture, but there's a greater variability in the distribution of serotypes. Reductions are driven by serotypes 19A and 7F, and serotype 3, which is in green again here, we have not seen any evidence of impact on this serotype through indirect or direct effects. And because serotype 3 has been a question of like what is happening, and is this like we are seeing absolutely no impact, there are studies that suggest that there's some direct effects from case control studies that there may be a direct effect, but at the population level we have not seen an impact. So we wanted to closer examine our ABC's data to see longer trends of due to serotype 3. So the graphs here present from 98 to 2017 rates of incidence of disease due to serotype 3 among children under 5 and adults 65 and older. So traditionally, we have always looked at the impact on serotype-specific disease by looking at the time period before, time period after the vaccine introduction, and measuring the impact. But what we wanted to do is assess in a different way, let the data tell us when the changes occurred. So we used this joint point analysis to essentially let the data tell us when the point of inflection in our rates occurs. So what we found that in children, there was a slight increase in serotype 3 disease, which is preceding PCV7 introduction, but then the slope really changed somewhere in 2003, and the confidence interval is like around 2000 to 2008, in that range where potentially the trends have changed and the slope in curve was changed. And that was before PCV13 introduction, and these reductions continued through 2017. However, you can see from the graph, just looking at those red dots, that if we were to look at just the time period before PCV13 introduction and after PCV13 introduction, that's where these trends would have not been apparent. So I guess the data suggests that there might have been additional benefits of the PCV introduction, but the trends going down for serotype 3 started really before PCV13 was introduced. And a very similar picture for adults, where we see this downward trend somewhere around year 2000 and continues through 2017. And looking at the short-term period, 2007, 2017, does not allow us to see this picture. Now looking at this disease caused by serotypes in the PCV13 era. So this graph presents the rank order of serotypes for children under 5. This includes vaccine serotypes. As you can see, serotype 3 and 19A still are ranked as top 10. These are the PCV13 serotypes. Now, because 19A at the baseline contributed to a large burden, I'm going to exclude this graph just to show you what the trends over time look by serotype, by this non-vaccine serotype. As you can see, some serotypes have increased, some have decreased, but we don't see a consistently emerging non-vaccine serotype. So not a very different picture from what we saw after the PCV7 introduction in the US. Now, I wanted to do a little exercise in terms of like what is the remaining disease burden, and point to the y-axis. As you can see, each serotype contributes to a very small relatively small disease burden. So if we were to take the two most common serotypes in 2016 and 17, 33F and 23B, so they contribute to like 16% of IPD. Now, let's take a hypothetical vaccine, PCV15, and I just want to say that all the hypothetical vaccines that I'm presenting, these are not any current vaccines in a pipeline, and they're truly hypothetical. It's all based on the rank order of serotypes. So hypothetical vaccine that contains PCV13 and additional 2 non-vaccine serotypes in children. These are 33F and 23B, and in total, the preventable burden is less than 2 cases per 100,000. And in terms of estimated US cases, it's around 260. So it's stuck again. And now if we take a hypothetical 20-valent vaccine, so that will be PCV13 serotypes plus 7 high-ranking pediatric non-vaccine serotypes, and they are listed here in the box. These accounted for 48% of IPD in 2016-17, but in terms of preventable disease burden, it's around 3 cases per 100,000. And in terms of estimated US cases, around 700. Now let's do the same for adults. If we were to look at the top-ranking pediatric serotypes in adults, So these are the ones with arrows, and also some at the end of the graph where they didn't even rank in the top 10. And if we take, again, a hypothetical 20-valent vaccine in children that contains 7 pediatric serotypes, these account to 35% of IPD in 2016-17 among adults. So this pediatric serotypes, but disease among adults. And preventable burden through indirect effects is around 11 cases per 100,000. And in terms of estimated US cases, around 10,000. But if we take also into account through indirect effects based on the previous experience, we expect around 60 to 70% reduction. You can see that the large disease among adults large burden of disease is preventable through indirect effects. Now, if we take the hypothetical 20-valent vaccine again, but in this case take top-ranking adult serotypes, non-vaccine serotypes, in addition to PCV13 serotypes, and they are again presented here with arrows. In terms of the disease preventable, 42% of IPD is caused by these serotypes, and preventable burden is 9 cases per 100,000, and in terms of estimated US cases is around 12,000. So around 30% reduction is expected through direct effects, and that is if we take into account the current vaccine coverage, around 45%, which we have achieved after only 4 years of the PCV13 use in adults, and around 60%, which is an average vaccine effectiveness if we take all the other serotypes that we have evaluated. So in conclusion, overall IPD incidence is significantly lower in 2016-17 following PCV13 introduction for children. These reductions are driven by serotypes 19A, 7F, and 6C. There are no changes in serotype 3 IPD during this period. At the population level, we didn't see any impact. And the rates overall have plateaued since 2014. PCV13 direct effects on IPD among adults 65 and older were likely very limited during this observation period because of the lack of the population level effect that we're observing. There is no evidence of serotype replacement, and what we see that is new hypothetical next generation PCVs covering top 7 pediatric strains would target a relatively small burden of IPD in children, around 3 cases per 100,000. But the same PCV for children has the potential of reducing a large disease burden in adults 65 and older through indirect effects. And I would like to thank my colleagues, especially Ryan Gerke, who has done all the analysis for ABC's IPD data.
Great, thank you. Are there any questions specifically about this presentation from committee members? If not, I think we can move on to the next presentation, please. Mr. Gerke.
Good morning. Today we'll discuss our efforts to estimate the impact of 13-valent pneumococcal conjugate vaccine, or PCV13, on a pneumococcal pneumonia among adults in the U.S. Streptococcus pneumoniae, or pneumococcus, is a common etiology of all-cause pneumonia among adults. However, the true burden of disease is unknown, and due to the limitations of available diagnostic tests. The ratio of bacteremic to non-bacteremic pneumococcal pneumonia is estimated to be around 1 to 4, but this was estimated before PCV13 introduction among children. Blood cultures have low sensitivity. A commercially available pneumococcal urine antigen test, or UAT, has a sensitivity around 75% and is not routinely used by all healthcare providers. Pneumococcal conjugate vaccine use among children has dramatically reduced invasive pneumococcal disease in adults through indirect effects. Additionally, studies have documented reductions in pneumonia hospitalizations among children through direct effects of vaccination, and also in adults through indirect effects. PCV13 has demonstrated efficacy and effectiveness against PCV13 type pneumococcal pneumonia in older adults. Given the uncertainties around the true burden of pneumococcal pneumonia and the importance of this outcome for future PCV13 policy decisions for adults 65 and older, we established the surveillance of the non-invasive pneumococcal pneumonia, or SNIPP for short. The objectives of SNIPP were to estimate the burden of non-invasive pneumococcal pneumonia among adults and to evaluate the impact of the 2014 ACIP recommendations for routine use of PCV13 among adults 65 and older. SNIPP case ascertainment is built into the active bacterial core, or ABC's, surveillance system. Cases are defined as adults aged 18 years or older who are hospitalized with a clinically or radiographically confirmed pneumonia and have a positive pneumococcal urine antigen test. Cases were excluded if they have invasive pneumococcal disease or if they had a prior positive UAT within the past 30 days, or if they were not a resident of the catchment area. Data collection has been prospective since 2015, with retrospective data collection going back to 2013. This gives us two distinct time periods. Years 2013 through 14 are considered our before the age-based recommendations for adults 65 and older, and I'll refer to this from here on out as our pre-PCV13 time period. Again, this is for adults. And then our post-PCV13 time period goes from 2015 to 2016, after the recommendations were in place. The SNIPP catchment area has 10 sites around the United States, with an average annual population under surveillance of 16 million during the study time period. This table shows the basic demographics for reported UAT positive cases from 2013 through 2016. When comparing cases in the pre and post time periods, we find a very similar distribution among cases for both age, gender, race, and ethnicity. This table shows the distribution of characteristics related to the diagnosis and treatment for reported UAT positive cases. A similar proportion of pre versus post PCV13 time period cases had community onset of pneumonia, a chest X-ray confirmed pneumonia, and ICU admissions. There were no differences in the median length of stay, the proportion who died, or the proportions with immunocompromising or chronic medical conditions. A slightly higher percentage of cases during the pre-PCV period compared to post received pneumococcal vaccine during hospital admission. In order to estimate incidence rates of pneumococcal pneumonia, we had to make several adjustments to the UAT case counts. We know that not all pneumonia cases are tested by pneumococcal UAT, so we adjust the UAT positive cases by the proportion of pneumonia that are tested by UAT. We also know that not all hospitals perform pneumococcal urine antigen tests, so we again adjust the UAT cases by the proportion of pneumonia in the catchment area that we're seeing at hospitals offering UATs. Finally, we know that UAT is not 100% sensitive, so we also adjust our case count by test sensitivity. This slide will help me walk you through the data we collect and how we estimate incidence from catchment area hospitals. If you imagine within this box are all hospitals in a defined catchment area. Hospitals in black represent hospitals that do not perform UAT testing. Hospitals in blue perform UAT testing and report cases. Within the box, sites obtain the total number of all-cause pneumonia discharges from all catchment area hospitals. Here, we define all-cause pneumonia as a patient with pneumonia or empyema as their primary discharge diagnosis ICD code, or with septicemia as their primary discharge diagnosis code, plus pneumonia or empyema in a discharge diagnosis in any position. And for brevity after this point, this is the definition I'm referring to when I say pneumonia. So from this total number of pneumonia discharges in the catchment area, select hospitals, shown here in pink and purple, pull a random sample of pneumonia discharges by month and age group, and collect information on UAT testing status among these patients. And this is what gives us the proportion of pneumonia tested by UAT. We next use a model to estimate the proportion of positive UAT cases, and we apply this proportion to the total pneumonia in the catchment area to calculate the total number of pneumococcal pneumonia. For our model, the first step was to model the proportion pneumonia tested by UAT as an outcome. We used a fixed effects logistic regression model, and we used the following inputs: the sample number of pneumonia cases and the number of pneumonia tested within the sample. Additional predictors in the model were year, age group, select hospital characteristics, and site. We tested for interactions, and the following interactions remained in the model: site by year, site by age group, and year by age group. Model output was the annual proportion of the pneumonia tested by UAT, and this was by age group, year, and hospital. Oops. The next step was to model the percent of pneumonia positive by UAT. Here, we used a generalized linear mixed effects model. We used the following inputs: the number of UAT positive cases and the proportion of pneumonia tested, which was estimated in the previous logistic regression model. Additional predictors in the model were age and year, here as fixed effects, and hospital and site as random effects. Model output was the annual proportion of pneumonia positive by UAT, and this was aggregated for all hospitals and sites included in the model by age group and year. This model made the following assumptions. UAT testing among pneumonia cases is assumed to be random after stratifying by hospital, age group, and year. The effects of hospital characteristics are assumed to be random, though the effects of the hospital can be different. So they can be different, but they have to follow it's assumed they follow a common normal distribution. And testing practices from hospitals reporting UAT cases follow a similar distribution as those not reporting. The final steps in the adjustment calculations were to multiply the estimated percent positive UAT obtained from the last step in the model by the total number of pneumonia cases in the catchment area. And finally, we inflate the case counts to account for an estimated UAT test sensitivity of 75%. The following table summarizes the estimated incidence of non-invasive pneumococcal pneumonia in the pre- and post-PCV13 time periods by age group. The second column from the left on the table shows the number of UAT cases reported to CDC. The next column shows the number of cases that are estimated after the adjustments were performed. And the final column on the far right shows the incidence of non-invasive pneumonia per 100,000 with 95% confidence interval. And this is calculated using the adjusted case counts as the numerator and the total catchment area population as the denominator. In the pre-PCV13 time period, adults 65 and older had the highest incidence of non-invasive disease, followed by adults age 50 to 64, and finally adults age 18 to 49. Comparing the incidence in the pre- and post-time period, we observe reductions in non-invasive disease among all age groups in the post-PCV13 time period. This graph shows the annual non-invasive pneumococcal pneumonia incidence by year for 2013 through 2016. Here, adults age 18 to 49 are shown in blue, adults age 50 to 64 are in orange, and adults age 65 and older are in gray. Incidence estimates reported on the previous table. So if we pull in the incidence estimates that I reported on the previous table and use them to calculate the percent change, the percent decline, we observe a 35% reduction in non-invasive disease among adults 65 and older. And we observe a 12% reduction among adults age 50 to 64. And finally, again, a 35% reduction among adults age 18 to 49. and the rate reductions in adults age 65 and older and ages 18 to 49 were statistically significant. However, you can see that the majority of reductions occurred in years between 2013 and 2014, and this was before the PCV13 recommendations in adults. These are likely the results of continued indirect effects of PCV13 vaccination in children. If we compare the year 2014 to 2016 among all ages, we find a rate ratio of 0.95 with a non-significant p-value of 0.53. So it appears there's not any significant changes in these later years. We wanted to compare whether the changes we see from non-invasive disease are consistent with the trends in invasive disease. These graphs compare changes in non-invasive pneumonia to bacteremic pneumonia during 2013 through 2016. The graph on the left is the previous slide shown with non-invasive pneumococcal pneumonia from SNIPP. The graph on the right shows the incidence of invasive pneumococcal pneumonia from ABCs for the same time periods and among the same age groups. First, please note that there's a difference in scale between the two graphs. The key points we can draw from this comparison are that non-invasive pneumonia incidence is 3 to 7 times higher than invasive pneumococcal pneumonia. Changes in the incidence of invasive and non-invasive pneumococcal pneumonia appear to follow a similar pattern, with the majority of declines observed again in that 13 to 14 time period. We're not observing additional reductions in disease after the 2014 recommendations for either invasive or non-invasive disease. Our findings have the following limitations. UAT testing practices at hospitals are likely not at random. Our adjusted incidence is based on ICD-9 codes for pneumonia, and coding practices may change over time among hospital and site. And we have a relatively short time period for both the pre- and post-PCV13 time periods. Serotype distribution of UAT-positive cases is unknown, so we're unable to determine the burden of vaccine type pneumonia. And it's possible that increases in non-vaccine type pneumonia are minimizing the reductions observed. Finally, the direct effects cannot be estimated without pneumococcal vaccination status of cases. In conclusion, pneumococcal pneumonia continues to contribute to a high burden of disease among adults. We observed the most dramatic decreases in pneumococcal pneumonia before 2014, and these reductions were likely driven by continued indirect effects from PCV13 use among children. We saw no additional reductions after 2014, and the changes in incidence of pneumococcal pneumonia are similar to those observed in invasive pneumonia during the same time period. And I'd like to acknowledge the following. Thank you.
Thank you very much for that excellent presentation. Are there any questions related to this presentation? Yes, Dr. Fry.
I found the graphs where we see an increase in non-invasive pneumonia compared to decreasing invasive pneumonia, if I interpreted that graph correctly, to be interesting. And do we have any sense that perhaps the vaccine is partially protective in the sense that it could protect against the invasive pneumococcal pneumonia or bacterial with bacteria infection of the blood, and we're seeing more non-invasive but less invasive because it's only partially protective? And that didn't make a whole lot of sense, but did it make sense? Okay.
Were you asking if the vaccine is less effective against non-invasive compared to invasive disease? The other way?
I guess what I'm trying to say is the incidence of non-invasive going up while we see the invasive going down, the incidence of invasive pneumonia going down, simply because the vaccine is partially protective.
I think it's hard to, again, it's a short time period. It's hard to draw conclusions, and as I said, that 2014 to 2016 comparison for non-invasive disease was not significant, so I think we need to see, there is annual variation in pneumococcal disease, so we'd have to see in 2017 if it continues down. We're not sure that this is an actual increase.
Dr. Lee?
Does that answer your question? Okay, thanks.
Thank you. I was wondering if there was sufficient information available on a yearly basis that this could be treated more as a time series as opposed to a pre-post, since the pre actually still is capturing that impact of the infant vaccination program.
That is something we would like to do, but we're still working on the modeling, so we haven't gotten to that point yet.
Dr. Atmar?
I just have a question in terms of the annual impact of the size and extent of the influenza outbreaks that we have each year on the variability you see from year to year with both invasive and non-invasive pneumococcal disease.
On outbreaks, you said, I'm sorry?
So flu is a predisposing factor for development of pneumococcal disease. And I was just wondering, you had a bunch of things in your models to try and look at what would predict pneumococcal disease. And I wondered if you had used the flu outbreaks or flu epidemiology for that.
Okay, we have not looked at any other, the interaction with any other disease at this time, but that is something we could look into.
Yeah, maybe we could ask for a little clarification.
Yes, I mean, certainly we have tried to look at it in our previous IPD analysis where we, for example, in 2009, we knew that 2009 was a bad year. So we actually had to take out 2009 from all our comparisons because it was definitely, there was a spike in a disease. But going forward, we could probably combine in with Dr. Lee's comment as to looking at it more as time series and looking at when we have more data points, we could probably look at different influenza seasons and their contribution to the trends that we're observing.
Dr. Welter?
Yeah, I was just trying to tease out the 2013 to 14 decrease and looking at the time sequence for change in policies. And what was indirect benefit and potentially direct benefit from the change in 2012-13 for immunizing people with immunocompromising conditions?
So I do not believe that contributes significantly to, it's a very small number of cases that I believe received that recommendation, so I don't think that would be influenced. It might be influencing it a little bit, but it's mainly driven by the indirect effects in children.
I think I just wanted to point out, and I didn't appreciate this earlier, that the scale on the graph for the invasive pneumococcal pneumonia incidence is quite a bit different than the one on the left.
It is. I tried to point that out in the presentation, but.
Thank you.
At the back, Luis, please introduce yourself.
Yes, thank you. I'm Luis Joder. I'm the Chief Medical Officer of Doesn't? Should I shout? Oh, here. I'm Luis Joder. I'm the Chief Medical Officer for Pfizer vaccines. Thank you very much for the presentation. I just have a couple of comments with regard to the comments about the effectiveness of the vaccine against non-invasive pneumonia. First of all, there is convincing data that the vaccine protects against vaccine type non-invasive pneumonia, both in the CAPITA, which is a randomized double-blind control efficacy trial with 80,000 participants, and then an effectiveness trial that was presented here. The second comment is that obviously the time period, and I think you've mentioned, and I completely agree, from 2015 and 16, well, it has to show, I guess, what was the uptake of PCV13. I mean, people need to remember that the recommendation was not until August 2014, and then after the MMWR, so the uptake is low. And finally, the UAT does not discriminate between the 13 serotypes. It's just pneumococcal serotypes. So I don't think that it's fair to say that the vaccine does not work against the 13 serotypes. Thank you.
Okay.
Thank you. And just to clarify, I don't believe that comment that the vaccine doesn't work against these serotypes was made by anyone.
No,
So-
yeah.
Great. Well, I think we can move on to the next presentation then. Dr. Lassa.
Hi, good morning. The title of my talk is Impact of Introduction of Infant Vaccination with 13-valent pneumococcal conjugate vaccine, PCV13, on pneumonia and invasive pneumococcal disease in the United States from 2005 through 2014. And this work was really a huge collaboration between CDC, academic partners, and departments of health. So decreases in pneumonia and IPG hospitalizations were observed in the United States in both vaccinated and unvaccinated population after pediatric 7-valent PCV7, was introduced in 2000. Rise of non-vaccine serotypes, especially in 19A, led to the switch from PCV7 to PCV13 in the United States in 2010. The objective of our analysis was to determine if pediatric PCV13 introduction in 2010 resulted in further declines in pneumonia and IPG hospitalization rates in US, given the additional serotype protection. To address this question, we used statewide hospitalization data from 23 US states. We analyzed a total of 73.4 million hospitalizations in the pre-PCV period, defined as January 1st, 2005 through June 30th, 2009, and a total of 69.7 million hospitalizations in the post-PCV period, defined as July 1st, 2010 through December 31st, 2014. We did not include any data after 2014 to allow for measurement of indirect effects of the pediatric PCV13 introduction on pneumococcal disease among adults. We evaluated 3 outcomes defined by ICD-9 codes: all-cause pneumonia, pneumococcal pneumonia, and IPG. IPG was defined based on a combination of ICD-9 codes that included pneumococcal-specific codes and codes for invasive disease. Hospitalizations not meeting our case definition were grouped into categories using a classification software based upon their clinical similarities to one another to serve as control conditions. We use the synthetic control method. For those of you who are not familiar with synthetic control method, it was developed by Google for market research and has been validated for use on hospital administrative data to measure vaccine impact. This method provides a data-driven way to select a combination of control conditions to better adjust for unmeasured confounders present when analyzing administrative data, such as changes in healthcare utilization or in the underlying health of the population. Data were analyzed for each outcome stratified by age. Our null model was a simple time series of monthly incidence controlling for seasonality. Our synthetic control model was a time series model account for a composite synthetic control instead of a single control condition. Rate ratio of less than 1 was considered vaccine impact. All-cause pneumonia represented around 15% of all hospitalizations for the younger age groups, and around 10 to 12% for the older age groups. Hospitalizations coded as pneumococcal pneumonia were very uncommon and represent less than 0.4% in our data set. This graph shows the rate ratios and the 95% credible intervals per year post-PCV13 introduction for the null model in green and the synthetic control model in orange, using all-cause pneumonia as the outcome of interest. So for children less than 2 and 2 to 4, declines in all-cause pneumonia were observed after 2011 and 2012, respectively. For children 5 to 17, no declines were observed, with exception of 2014, when we adjusted for controls. For adults, no declines in all-cause pneumonia after pediatric PCV13 introduction was observed. Moving on to pneumococcal pneumonia, declines on pneumococcal pneumonia hospitalizations were observed across all pediatric age groups, with declines ranging from 25% to 60% in some years post-PCV13. For adults, declines in pneumococcal pneumonia were also observed, with the exception of the age group 75 and older, where the credible intervals of the synthetic control model crossed 1 for 2013 and 2014. Finally, for invasive pneumococcal disease, or IPD, declines were observed for children less than 2 years from 2010 forward. In the age group 2 to 4, there was no decline during the year of vaccine introduction, and then for children 5 to 17, no declines in the first year after the introduction, but then with declines afterwards. For adults, the age group 40 to 64 and 75 and older did not experience any declines after adjusting for confounders. Overall, from June 2010 through December 2014, the cumulative number of cases prevented for all-cause pneumonia in children was over 38,000 in the age group less than 2, and over 17,000 for the age group 2 to 4. For pneumococcal pneumonia, the number of cases averted ranging from 743 for children less than 2 years to over 5,000 in adults. For adults 75 and older, even though the 95% credible interval crossed 0, up until 2013, there were over 6,000 pneumococcal pneumonia hospitalizations averted with a credible interval that did not cross 0. For IPG, the total number of cases averted in the post-PCV13 period across the 23 states ranged from 335 in children to over 1,200 in adults. In summary, declines in all-cause pneumonia were only observed in children less than 5 years old after PCV13 introduction. Pneumococcal pneumonia hospitalizations declined in all age groups, but for adults 75 and older, no significant declines were observed in 2013 and 2014. No decline in IPG hospitalization for age groups 40 to 64 and 75 plus were observed. There are several limitations to this data analysis. Even though we use a robust methodology to try to overcome some of the limitations of using administrative data sets, changing hospital coding practices during analysis period may affect trends over time. The outcome of all-cause pneumonia is very sensitive and also include healthcare-associated pneumonia hospitalizations. Finally, administrative data likely underestimate specific outcomes related to pneumococcal disease. Comparison of our US active population-based surveillance data, the ABCs, with this administrative data reveal underreporting of IPG, especially for adults. In conclusion, the lack of measurable impact on all-cause pneumonia in persons greater than 5 years old is likely related to the use of non-specific outcome, Only a small fraction of all-cause pneumonia is vaccine-type pneumococcal pneumonia. And also, PCV7 was in place for a decade prior to PCV13 introduction. Therefore, small benefits are expected for all-cause pneumonia. Direct and indirect effects were observed for pneumococcal pneumonia and IPG hospitalizations after switching to PCV13. No decline in IPD hospitalization among 40 to 64 and 75 plus when adjusting for confounders. So we had very wide credible interval for those age groups. And as I mentioned before, there was indication of underreporting of IPG using hospital administrative data when compared to our population-based surveillance data. I want to thank our collaborators, and that's all. Thank you.
Great, thank you. Do we have any questions specifically related to this presentation? No, then I think we can go on to the next presentation. Dr. Stoker.
Hi, I'm here to present the economic evaluation of continuing to recommend PCV13 at age 65, and I have no conflicts of interest to declare. So the study question here is to evaluate the cost effectiveness of continuing to recommend PCV13 at age 65 for all adults. Essentially what we're doing here is trying to evaluate how well the protection offered by PCV13 matches what the current disease burden is and what the projected disease burden will be. And what we're going to do is we're going to incorporate some updated estimates of the herd protection provided by the childhood PCV13 immunization program. We're going to evaluate the costs in both medical and non-medical costs and changes in disease, and we're going to aggregate disease endpoints into quality-adjusted life years, which are going to be an index measure which ranges from 0 to 1, 1 indicating a person in perfect health. The intervention here, as described, is to continue the age-based recommendations for PCV13 at age 65. So that would be PPSV23 for those with underlying medical conditions between ages 19 and 64, and then PCV13 at age 65, followed by a dose of PPSV23 a year later or when at least 5 years have passed since the previous dose. This model that I'm going to present today excludes the immunocompromised. Prior work that we've done indicated that this population was vaccinating this population was cost saving. So we anticipate keeping that recommendation. The comparison strategy is going to be a strategy that includes the PPSV recommendation for those with underlying medical conditions at age 19 to 64, but then at age 65 only has a recommendation for PPSV23. So removing that PCV13 at age 65. And again, the comparison strategy keeps the same recommendation for the immunocompromised. This is going to be a cohort model, which is going to track 65-year-olds until 100 years old or until death. We're going to incorporate disease rates prior to the 2014 PCV13 recommendation for direct vaccination in adults. And we're going to project indirect effects from the pediatric program ahead through the lifetime of the cohort. All outcomes and costs are going to be discounted by 3%, and all costs are going to be presented in 2017 dollars. So there are 2.6 million adults in our cohort model. This excludes the immunocompromised. 43.8% of these are going to be those with chronic medical conditions, referred to as CMC, which is defined as those with chronic heart disease, chronic lung disease, diabetes, alcoholism, or chronic liver disease. We're going to calculate the incremental cost effectiveness ratio of the two recommendations. We're going to calculate the costs and benefits under one vaccination strategy and the other, and then divide those to get the cost effectiveness ratio, and that's going to be our primary outcome metric. And this analysis is going to be conducted from the societal perspective. The disease outcomes we're going to track are going to be cases of invasive pneumococcal disease, IPD, cases of inpatient non-invasive pneumococcal pneumonia, henceforth pneumonia, cases of outpatient pneumonia, deaths due to IPD and pneumonia, QALYs, and then life years. Here's our conceptual model, which starts with the study population. We'll run the model once for Schedule A and again for Schedule B under each of the assumption scenarios that I'm going to present in a second. People can be vaccinated or unvaccinated, get 3 different diseases, IPD, pneumonia, or maybe nothing. And in IPD, they can have an inpatient visit or death, and in pneumonia, they can have an inpatient visit or an outpatient visit, or potentially also death. So here's the first table of inputs. These are going to be the inputs for invasive pneumococcal disease taken from ABC's data, again, prior to the direct vaccination recommendation for adults at age 65. We're going to break the model down into healthy and those with chronic medical conditions. You can see that the rates per 100,000 for IPD are 15 for the healthy and 36 for the CMC population. There's about a 14% fatality rate among both those populations. And then we turn to the serotype distributions. The one I want to highlight here is serotype 3, which represents 12% of the total IPD disease, but this represents almost half of the vaccine serotype disease in the 2013-2014 data. These are the inputs for the pneumonia disease burden. For the inpatient all-cause pneumonia rate, we're going to take the lower bound from a study in Chicago and Nashville and the upper bound from a study in Louisville, and then our base case is going to use the midpoint between those two. We're going to decompose those estimates into healthy and chronic medical condition populations by using the ratio in a third study. You can see it's about 3-to-1 there. Our case fatality rate for pneumonia is going to be 3.9% in the base case, and we're going to take this from the national inpatient sample in 2014. The outpatient all-cause pneumonia rate is going to be from a 2008 study, and the percent of pneumonia due to PCV13 serotypes is going to be from Pfizer data. So our base case is going to be from a Pfizer study from October 2013 to September 2014. And then we're going to construct some confidence intervals around that. We're going to use, as a lower bound, we're going to use data from the 2015-2016 Pfizer study. And then we're going to construct the upper bound by symmetry around that. These are our assumptions for the vaccine effectiveness. We need to estimate vaccine effectiveness separately by serotypes, as you've seen some evidence that serotype 3 seems to behave differently. Our vaccine effectiveness against IPD is going to come from a CDC case control study. That first line there indicates in the base case it's going to be 67% effective. Against serotype 3, in the base case, we're going to assume it's 0% effective, but we're also going to conduct sensitivity around that, where we assume it's as high as 26% effective. Against pneumonia, we're going to draw the estimates here from the Capita trial. The estimate for the healthy is from the original Capita trial, and for the chronic medical conditions, it's going to be from a post hoc analysis, 41.1 and 32.5 effectiveness, respectively. For the effectiveness of PCV13 against pneumonia, again, we need to break this down by serotypes. We're going to assume it's 0 in the base case, and we're going to assume that it as 45% effective, which is going to assume that it's as effective as the per protocol analysis in Capita. For the polysaccharide vaccine, we're going to assume that it's as effective against IPD as the conjugate vaccine, so 67%. We're going to construct error bars around that from a meta-analysis. And for the effectiveness of the polysaccharide vaccine against pneumonia, we're going to assume it's not effective in the base case based on several meta-analyses, but we are going to conduct sensitivity analyses where it has a much higher effectiveness. For the indirect effects of the pediatric immunization program, we're going to assume in the base case that there's a 4.1% decline in these serotypes per year, and here these serotypes are serotypes 1, 4, 5, 6A, 6B, 7F, 9V, 14, 18C, 19A, 23F, and 6C. And we're going to assume that that applies to both pneumonia and IPD. And then we're going to assume no further indirect effects on serotypes 19F and 3. These results are from a study that was presented to ACIP 2 meetings ago, I believe. For the coverage rate for PPSV23, we're going to draw this from the NHIS in 2014. For PCV13, we're going to take the midpoint of estimates from CMS coverage data and Pfizer claims data of 40%. For the vaccine price, we're going to assume that PCV13 costs about $200 per dose, and that's derived as 95% of the average wholesale price. For the polysaccharide vaccine, it's about $100 per dose, derived similarly. Vaccine administration is going to be $26.61, and that's going to be the average across all Medicare administrative contractors in 2017. And travel and time costs we derive from prior work and then inflate it to $2017 for consistency. Costs for to treat an episode of disease are derived from Medicare claims from 2010 to 2015, and those are all going to be, again, inflated to 2017. IPD costs about $21,000. Inpatient pneumonia costs about $11,000, and a case of outpatient pneumonia costs about $300. We need to aggregate these disease endpoints into a single quality metric. And what we're going to use is we're going to use quality decrements, which indicate how much of a healthy life year you lose when you contract this disease. We're going to have two sets of quality decrements. The first one is the base case estimate here, and these are derived from several studies that tried to elicit these values from patients. In the base case, IPD is going to cost 0.008665 of a healthy life year. And that's going to be equivalent to 3.2 days of healthy life lost. So the implied duration of a case of IPD is 21 days here. If you use the assumption that a case of inpatient pneumonia or IPD is about 85% of a healthy day. And then these numbers are going to be discounted according to how the baseline health of the person is. So a person with chronic medical conditions or an older person is going to have a lower baseline utility level and thus is going to achieve a lower decrement. For our alternative quality sources, we're going to use a different study that used much higher decrements, about 10 times as the previous. So the equivalent healthy days lost of a case of IPD is going to be 27.2 days, and that's going to be an implied duration of illness of 181 days. And we'll present sensitivity around this. For the immunity conferred by the two vaccines, we'll present two scenarios for PCV13. In scenario one, there's going to be no decline in vaccine effectiveness between age 65 and age 70, and then from age 70 to age 85, there will be a linear decline to 0. In scenario two, it's going to be a slower waning, but it's going to start at age 65, and it's going to decline by 10% every 5 years starting at age 65. For PPSV23, we assume that all protection disappears within 15 years after vaccination, according to the schedule here. Here is the first table of results. The base case column indicates that there are 82 discounted cases of IPD prevented over the lifetime of this cohort. That represents a number less than 1% of the total cases of IPD across this cohort. Inpatient pneumonia cases are 1,772, again representing some number less than 1% of the total number of inpatient pneumonia cases in this cohort. Skipping down to the costs number, the total net costs is $401 million. And that's composed of $423 million to vaccinate this cohort and combined with the savings of $22 million in direct medical costs. So the headliner number is $648,845 per QALY in the base case. And then you can see the 95% confidence intervals to the right. We're going to present 4 one-way sensitivity analyses. The two at the top are going to be the most important. So in the base case, we assumed that the polysaccharide vaccine was ineffective against pneumonia, but in some sensitivity analysis, we're going to assume it's actually 45% effective, which is going to be as effective as the per protocol effectiveness of the conjugate vaccine against pneumonia. For PCV versus serotype 3 disease, again, based on case control study and measurement of serotype rates, we're going to assume it's 0 in the base case. In sensitivity, we're going to assume that it's at the highest level that was at the ranges that you saw presented. So 26% versus IPD and 45% versus pneumonia. We're also going to conduct the sensitivity I mentioned around the quality decrements. So in the base case, we have the smaller quality decrements, and then in sensitivity analysis, we're going to look at much larger quality decrements. And then we're going to look at the impact of our waning for PCV13 has on the quality ratio. So here are the results from the two important sensitivity analyses. Again, looking at that second to bottom line, which is the headliner number. In the base case, it's about $650,000 per QALY. If we assume that the polysaccharide vaccine is highly effective against pneumonia, it comes out to $3.7 million per QALY. If, however, we assume that the PCV is effective against serotype 3, 26% versus IPD, 45% versus pneumonia, it costs about $250,000 per QALY. We also looked at the impact of the larger quality decrements. So we went from $650,000 to $560,000, not a huge change. And also when we changed our assumptions about how PCV13 waned, that didn't have a very large impact on the cost effectiveness ratio either. So now I turn to some multivariate sensitivity analyses. So to generate these, we run a model 50,000 times and draw inputs at random from the distributions as specified. About 80% of those runs cost some amount less than $1 million per QALY. About 50% of those runs cost some number less than $600,000 per QALY, and less than 1% of those runs cost some number less than $200,000 per QALY. This is a tornado diagram, again from the multivariate sensitivity analysis, and this shows the importance, the relative importance of our assumptions about various inputs into the model. The width of the bar indicates the impact, so you can see the most important number is the vaccine effectiveness of the polysaccharide versus pneumonia. So as that number gets larger, the cost effectiveness ratio gets higher. So the way to read these bars is when a number is either in the bottom 10% or the top 10% of the possible values for that number, this would be the mean cost effectiveness ratio for those runs. So for instance, when the model draws vaccine effectiveness against the polysaccharide vaccine in the top 90th percentile and above for that effectiveness, then the mean cost effectiveness ratio among those draws is $1.6 million per quality. The next most important input is going to be the impact of the indirect effects from the childhood program. And all of these, and the rest of the inputs here deal something with pneumonia, indicating that the pneumonia results seems to be what's driving this model. So I want to compare between the results I presented today and the results that we presented in 2014 before the recommendation then. So to recap, the 2014 analysis, after converting to 2017 dollars, indicated that the cost per quality of recommending the conjugate vaccine at age 65 was about $65,000. But at the time, we projected that it would rise to nearly $300,000 per quality next year. So this 2018 analysis indicates that in the base case, it costs $650,000 per quality. So after using some updated numbers, the cost per quality has increased substantially. And so I want to highlight some impacts of the chief differences between the two studies. First, in this study, we're assuming the direct effects are about half the size. So in the 2014 analysis, we assumed that the indirect effects were about 7% per year, and here we assume they're 4.1% per year. That 7% was based on experience from the 7-valent conjugate vaccine, and the 4.1% is again based on modeling using actual data since vaccine introduction. The second difference is that we assume that PCV13 is ineffective against serotype 3 in the base case. This is based on both the case control study and observations of disease burden over time. The third difference is that the burden of PCV13 type pneumonia disease here in the base case is assumed to be 5.1%. In our 2014 model, we assumed it was 10% based on capita data. So the lower incidence is based on population more relevant to the United States. And then the fourth reason is that we decomposed a pneumonia burden by risk status using that third study to indicate that the chronic medical condition population actually has a rate about 3 times as high as the healthy population. All right, so I'd like to thank my contributors and everyone for their time.
Great. Thank you so much for that very clear presentation of some very complicated data. Any questions from anyone in the committee specifically about this presentation? No? Okay. Do we have a comment from Dr. Sturz in the back?
Hi, good morning. My name is Raul Isturiz. I'm the U.S. lead for Pfizer Vaccines Medical. Thank you for a very interesting presentation. I want to make a comment about one fundamental assumption that you have made, and that is the lack of effectiveness of PCV13 against serotype 3 disease. This is probably not so. The effectiveness of PCV13 against serotype 3 is not zero. It's not zero in pediatrics, and it's not zero in adult disease. Let me give you 4 pieces of data to back that up. One, a meta-analysis just published about all available evidence in Europe, and also the CDC case control study that was published in 2016. They estimate the effectiveness of PCV13 against serotype 3 disease at upwards of 50%. 2 would be the 3 adult pneumonia studies, pneumococcal pneumonia study, CAPITA, the Louisville test negative design study, and a smaller study in Argentina, all of which showed around 50% efficacy of PCV13 against serotype 3 disease in older adults. 3, in the US, the situation, I believe, is very interesting. In a different analysis than the one that Dr. Pilishvili presented, we can clearly see that since the introduction of PCV13 in the childhood NIP in the United States, there's been a steady decrease in cases of serotype 3 IPD, about 60, 61 cases per year for a total of about 480 cases in the last 7 years. At the same time, this has not happened in adults. In adults, the disease, the serotype 3 disease has remained about the same or perhaps gone up a little bit. There must be a difference there because the less than 5-year-old children have been vaccinated and many adults have not been vaccinated. But also, it is notable that PCV13 does not heavily impact nasopharyngeal carriage of serotype 3, and that may explain the lesser perceived efficacy in a population based. And fourth, it's really interesting that in countries that do not use PCV13, the increase in serotype 3 has been dramatic. And this suggests that if you took away from these countries PCV13 in adults, the disease would be even higher after the decrease of vaccination rates. So all in all, the available data on effectiveness shows direct impact of the vaccine against against serotype 3 of PCV13, and the effectiveness is not zero. This is very important because small assumptions of effectiveness of PCV13 on serotype 3 disease have a tremendous impact on the cost per quality. So I believe that there is enough evidence to say that serotype 3 is impacted by PCV13 and that using 0 in the base case is wrong and maybe misleading. Thanks.
Thank you very much. Okay, can we, it looks like we actually have one more comment from Dr. Presence.
Yes, thanks. First of all, it was a terrific piece of work that's been done here, and really commend you for it. And actually, your delivery has made it very clear. Kind of a similar comment, but on the other side, in terms of, and it's not going to really change the cost-effectiveness analysis as a base case, is the assumption that there's 0 effectiveness for PPV23 for non-bacterial pneumococcal pneumonia. I'm not going to go through all the details. You cite the meta-analyses, including Falkenhurst, which did a very comprehensive review. And there have been a number of studies that have been published over the last few years since 2014, which basically show that vaccine effectiveness against non-bacterial pneumococcal pneumonia is not 0. One could argue what it really should be. And as I said, including, your sensitivity analysis shows that it makes this cost-effective analysis worse. But what I would urge is that when the GRADE analysis is presented in February, that basically there's some discussion about those additional studies that were published in 2014 and give some assessment. Methodology is different in these studies, but they do have some value. Thank you.
Thank you very much. And Dr. Bresowitz, can you just clarify where what your affiliation is?
Sorry, Merck Vaccines.
No problem. Thank you. One more comment.
Yes, I'm Peter McIntyre from the National Centre for Immunisation Research in Australia. I'm not affiliated with a vaccine company. But I did have 2 questions and 1 comment. The questions related firstly to the fact that the SNIPP data indicated, and this would be consistent with other data, that about 80% of the identified pneumonia cases occurred in individuals with underlying conditions. And yet in the model, you only have the incidence amongst those with underlying conditions being double those without, whereas I think the proportion occurring in those with underlying conditions suggests that it's somewhat greater than that, and I think that has implications for vaccine policy decisions. The second question was about waning, and I think the the single best study of efficacy of 23-valent vaccine against IPD, not pneumonia, found that almost all the effect had gone within 2 years. And so the waning assumptions, I think, may be overly generous. And I guess thirdly, as a general comment, that it seems extraordinary that we have 2 vaccines which have been in production for more than 20 years, in many cases much longer than that, and yet list prices that you're quoting are $200 and $100 respectively, which seems quite extraordinary in relation to other vaccines which have been in production for similar periods of time.
Thank you. Do you have any other final comments or any?
Yeah, just a
questions you want
response to the
address?
80%. So in our, we assume that 66% of pneumonia occurs in the CMC population. So that's roughly consistent.
Great, thank you. We have one last presentation before discussion on this session.
Good morning, thank you. I'm going to summarize the evidence presented thus far before further discussion. For adults, in 2012, ACIP recommended PCV13 in series with PSV23 for adults 19 years and older with immunocompromising conditions. In 2014, ACIP added an age-based recommendation for PCV13 in series with the previously recommended PPSV23 for all PCV13 naive adults 65 years and older. At that time, a commitment was made to reevaluate and revise this recommendation as needed, which is where we are today. The current policy question for consideration is, should PCV13 be administered routinely to all immunocompetent adults aged 65 years and older, given sustained indirect effects? For our PICO question, our population is immunocompetent adults 65 years and older. Our intervention is PCV13 at 65 years old in series with PPSV23 in the context of indirect effects. And the comparison is PPSV23 alone at 65 years or older. The outcomes are pneumococcal disease and PCV13 safety. Our guide for bringing together the evidence is the EtR framework, which Grace mentioned before. In this presentation today, I will focus on the statement of the problem, why it is a public health priority, and what the burden of disease is, and then walk through what we have reviewed so far in terms of benefits and harms of PCV13 use amongst adults 65 years and older. The highlighted topics from the EtR are being reviewed using GRADE. For the GRADE process, we are reviewing IPD, non-invasive pneumococcal pneumonia, and PCV13 safety. To measure these outcomes, we are looking at population trends in disease outcomes, indirect and direct effects of PCV13. Looking at IPD, there has been a dramatic decline since pediatric PCV introduction in 2010. Annual rates of PCV13 type IPD have gone from 14 per 100,000 in 2010 to 5 per 100,000 in 2014. This represents a 40% decline. Rates have plateaued since 2014, as Tamara presented. Mortality has not changed since the introduction of PCV13 for pediatrics. And currently, greater than 50% of the remaining PCV13 type IPD is caused by serotype 3. This is from Tamara's presentation today, showing the reductions in PCV13 IPD in orange after pediatric vaccine introduction in 2010, and non-PCV13 types shown in gray as a combined group here have been relatively stable in this time period. This slide shows the results of a model that used ABC's IPD rates before and after the 2014 recommendation for older adults to try to separate out direct and indirect effects. This was presented in February. When looking at all PCV type IPD, including 6C in the first row, there was an estimated 192 projected US cases prevented through PCV13 direct effects, which was not statistically significant. However, excluding serotype 3 in the second row, the projected US cases prevented through direct effects are significant. Looking at direct effects in vaccine efficacy and effectiveness against PCV13 type IPD, in light blue is the information that was available in 2014, and in darker blue is the information that has been presented since then. Bonden et al., the CAPITA randomized control trial, estimated an efficacy of 75% against PCV13 type IPD. Using ABC's data with two different methods for obtaining controls, PCV effectiveness against IPD was estimated to be 47 to 59%. Now to address invasive pneumococcal pneumonia. This is where the majority of the disease burden is, especially in older adults. However, it is more difficult to measure, as we have been discussing today, because there are less standard diagnostic methods. Many studies take a broad approach to measuring pneumonia and look at all-cause pneumonia. The range here is bounded by the Jane study and Ramirez, both of which cases of pneumonia were verified by clinical criteria. Whereas the other three studies in the middle of this range used ICD codes. Differences in inclusion criteria, primarily if patients with immunocompromising conditions and recent healthcare exposure are included, and what ICD codes define pneumonia likely lead to this wide range. When measured with serotype-specific UAT, approximately 5% of all-cause pneumonia in adults is caused by PCV13 serotypes. And the in-hospital case fatality for pneumonia is somewhere between 4 and 9%, likely again dependent on the patient population. This graph displays the studies that have measured pneumococcal pneumonia specifically. Walking through them, Simonson, a Pfizer-funded study, used specific pneumococcal pneumonia-related discharge codes, as Fernanda was discussing in her presentation, similar to that one. And for this reason, they may have underestimated the incidence, since there are likely patients with pneumococcal pneumonia who are discharged with a less specific pneumonia code. The remaining 4 studies measured pneumococcal pneumonia based on clinical diagnosis. The CAPITA trial is graphed here and is the incidence of pneumococcal pneumonia, both invasive and non-invasive, amongst vaccinated in red and unvaccinated in orange. This trial excluded immunocompromised. Rodrigo et al. Measured pneumococcal pneumonia using blood culture, serotype non-specific UAT, and a 14 serotype-specific UAT amongst adults admitted with radiographically confirmed pneumonia to 2 large hospitals in the UK. Healthcare patterns are different in the UK, making comparisons less direct. However, their estimates are close to those of the other studies. Jane et al., which excludes both patients admitted in the past month and those with immunocompromising conditions, had a low incidence. Here we have doubled that estimate published based on a reanalysis of the urine specimens using Pfizer's serotype-specific UAT as reported in Wonderluck, which doubled the number of cases that were detected. And lastly, the results from the non-invasive pneumococcal pneumonia surveillance, or SNIPP, presented today, which do not exclude previous admissions or immunocompromised individuals. They are slightly higher. They include not only adjustments for UAT testing practices, but also include an adjustment for the UAT test sensitivity. Again, this is the clinically available, not serotype-specific UAT. Not presented here are the pneumococcal-specific incidence estimates from the Louisville cohort, presented by David Swerdlow at the last meeting. From this study, we only have PCV-type pneumonia incidence, not all pneumococcal pneumonia. we can apply some ratios of distribution in IPD and discuss that further, but that is why I have not included them on this slide. As for IPD, indirect effects have been observed in most studies which examine rates after pediatric PCV introduction, but before 2014. The declines were modest when looking at all-cause pneumonia, but still significant. The largest effects are seen with more specific codes such as lobar pneumonia, and they appear to be less consistent in the older ages. As presented today in our surveillance data, we observed a 35% reduction in non-invasive pneumococcal pneumonia among adults 65 years and older between January 2014 and December 2016, driven by the decline from 2013 to 2014. After the 2014 recommendations in older adults, 2 studies have been presented so far looking at combined indirect and direct effects. The first was presented at the last meeting and showed PCV13 type pneumonia among 65 years and older decreased by 31% between June 2014 and May 2016. As mentioned on the previous slide, in SNIPP, we observed non-invasive pneumonia to be decreasing, but post-2014, the time of total effects, i.e. both combined indirect and direct effects, we do not see a statistically significant decrease in incidence. Looking at the direct effects through vaccine efficacy and effectiveness against PCV13 type pneumonia, in light blue again is the information available in 2014, and in dark blue is the information presented since then. The CAPITA randomized control trial estimated efficacy of 45% against PCV type pneumonia. And since then, a cohort study using test-negative design estimated the effectiveness to be 73%. This is the same population that is included in the upper bound of all-cause pneumonia estimates in Ramirez et al. For safety, the study submitted for licensing to FDA here, again in light blue, showed no difference between treatment groups in serious events, including death, and no deaths were considered to be vaccine-related. Since the recommendation in 2014, an evaluation of VAERS data has been presented and published, as well as a cohort from 6 vaccine safety data link sites. Neither of these studies detected concerning safety signals. Again, here is the ETR with the outline. The elements still to be addressed include a summary of additional economic analyses, which we know are forthcoming alongside Charles's model presented today. Upcoming at ACIP meeting in February 2019, we anticipate having a completed GRADE, including the results of outstanding pneumonia studies and a completed evidence to recommendations framework. And a vote either in February or June of 2019, depending on your feedback and deliberations. So again, the policy question is, should PCV13 be administered routinely to all immunocompetent adults age 65 years and older in the setting of sustained PCV13 indirect effects? For today's discussion and going forward, which domains of the ETR framework warrant additional exploration regarding continued use of PCV13 in immunocompetent adults 65 years and older? Thank you again.
Thank you so much. Any questions or comments from the committee members? Dr. Atmar?
So for the benefits and harms, generally speaking, part of the framework is to reach a conclusion about benefits and harms. And that's the piece that ultimately we'll have to deliberate, but has the work group had any preliminary discussions, and really what has been the assessment to date, or what data are the work group awaiting to make such an assessment?
I'll take the first stab at this. So it's been a challenge, in part because there's so much uncertainty on pneumonia burden in particular and the proportion due to PCV13 serotypes. I think the harms has been more straightforward. In addition to that, thinking about the effectiveness of these vaccines on the pneumonia burden reduction and disentangling the direct versus indirect effects has been a challenge. So yes, we are careening towards that conversation, and I think some of the challenge will be ensuring that we have consensus. So we hope at the next meeting to be able to share sort of a clearer sense of the degree of uncertainty, as you saw those categories up there, as well as the benefit-risk balance. Is that fair? Paul, would you like to add anything?
Just that all the controversy and discussion in the work group has been very educational. And that as my role within local governmental public health is translating public health policy into clinical practice, it's going to be quite a challenge to explain this all to clinicians and to understand that I think the way to prepare clinicians for just understanding the issue is emphasizing the dramatic, terrific effects, indirect effects that has been happening already with vaccinating children. And I think we need to be educating everybody about that publicly and widely.
Dr. Messonnier? Yeah, I mean, maybe just to set the stage here, you know, we recognize that this is a really complicated decision, and it is why we're so happy to have you all wrestling with it with us. Part of the intentionality of the way that we present this is to give you time to mull it over. The work group obviously sits with this a lot longer and a lot more directly, but part of the pace question for you all here is for you to think about what you're seeing, how quickly you're seeing it. In order to really appreciate this issue, you have to have in the back of your mind all the data that they've presented over the course of the past year. And I think what we struggle with is how much data to present at a single time to make sure that it's fresh in your mind as you try and sort of wrestle with an issue which is going to require judgment when, as this situation is definitely true, there's more than one, the evidence isn't all consistent. So, I mean, today, if there's any advice you would have for the work group or for the CDC leads about additional things that would help you or context, they would certainly appreciate some feedback.
Dr. Romero?
So for more clarity, I think the question about the impact of PCV3, I mean, we've got this spectrum, the spread of nothing to 13, 14%. And so somewhere in between lies the truth. And so a better handle on that would at least aid me in coming to a decision.
Say that because of the degree of uncertainty around some of these estimates, and that's why we struggled, and Dr. Stocker did a phenomenal job actually accommodating the range of opinions on the work group calls over time to try and come up with the base case estimate. It's hard to know what the exact right answer is, but I think that the purpose of the sensitivity analyses for us was to be able to understand how much that really impacts our understanding of burden that is preventable in addition to cost effectiveness.
Is that Dr. Grock there? Oh, sorry.
I have a little bit of just most of the data that we see on the PCV13 direct effects are because of are starting in 2015, 2016 type of effect, yet the vaccine really was not even available until probably early 2015, and uptake being low. Are we going to see more data? I said something in one of the slides about seeing more data. Are we going to see more data on later years of the direct effect coming up?
Yeah, so one thing that is planned is looking at pneumonia discharges post-2014 and trying to tease out what the direct effects are there. And we were just talking, so this is hot off the press down here, to see if we could try to look at SNIPP, the data that Ryan presented today further out. But other than that, I am not aware of any upcoming information for looking at direct effects.
Dr. Schmader?
Ken Schmader, American Geriatric Society. I'm sorry to add to the complexity here, but we all know that the health states of individuals 65 years and above are widely heterogeneous, from fit to frail, dependent to independent, and it's hard to generalize, right? So I think it's really important to keep this principle in mind when interpreting epidemiology data and also impact of the vaccine on outcomes. So at one level, it'd be really useful to routinely report older age groups in the incidence data. 80-year-olds are different than 60-year-olds, so it'd be nice to have that. And I'd like to congratulate Dr. Lessa for showing 75 and above, and for also the work group to consider whether this will impact beneficially, that is the vaccine, on subgroups. Maybe this is useful in frail and functionally impaired individuals, or vice versa.
Thank you. Dr. Isinoli?
Yeah, I just wanted to make sure that I heard correctly that after the 2014 recommendation, that the uptake of the recommendation was about 40%. Has that stayed steady since 2014, or has it increased?
Yeah, I'm sorry I don't have that slide. It has been presented before. I think most recent updates were in the David Swardelow presentation at the last meeting, but it was a gradual increase, and we have, seen continued increases, although maybe the slope of the curve is not as great as it was sort of in the 2016 year.
Other comments? We have Dr. Bresnitz at the back of the room again.
Dr. Bresnitz, just a question whether in the February meeting you'll be presenting an update on the data on series completion to date in the real world, because I think that kind of informs the discussion as well in terms of policymaking.
Thanks for that feedback. We can include that information, yep.
Any other comments, feedback? Dr. Moore?
Thank you. I just had a quick question. It would be helpful to know about anything in the pipeline coming down the pike that we should be considering, if anything, with respect to PCV13 and whether to continue its use or not.
In terms of new vaccines?
Mm-hmm. I'm not on the work group, so.
Dr. Hoda?
Perhaps I can answer that. So, yes, Luis Joder, Chief Medical Officer, Pfizer Vaccine. So, as you already know, this is public. Pfizer is developing a 20-valent vaccine, and we have interactions with the CDC on progress on the clinical development program, and we will make decisions around presenting that in February as well, so that the ACIP members have the context on when next generation pneumococcal conjugate vaccines are likely to be available. Thanks.
Thank you. It looks like we have one more comment.
Yeah, and just to answer the question, yes, Merck is also working on an expanded PCV15 serotype.
Great, thank you. It's getting close to 12:15. Do we have any other final comments before the committee? My sense from the committee is that y'all still feel like you're going to need additional time to deliberate past February. Is that a general consensus from the committee members? Or does it depend on sort of the data that's presented? Okay. Okay, well, we will break for lunch now.